For Megan Lena, the letter showed up sometime in the spring. Her pharmacy benefits manager, CVS Caremark, was telling her that come July, they wouldn't be covering Zepbound anymore. By that point, she'd already lost 50 pounds in a year on the drug, and she'd been paying just $30 a month for it. Once that letter landed, that was the end of that arrangement. So she switched over to Wegovy, which was the drug CVS Caremark had picked as the new preferred option. And it worked for her. But then in October, her employer's health plan turned around and dropped Wegovy too. That same month, her monthly health insurance premium jumped by 20%. Her school district's insurance trust actually sent out a letter explaining why. The reason they gave was the cost of GLP-1 drugs, the very same drugs her plan had stopped covering for her. Lena is a special education teacher in Massachusetts, and what happened to her is just one piece of a much bigger pattern. Between 2025 and 2026, 12 million Americans lost commercial insurance coverage for Zepbound. Over that same stretch, another 12 million lost coverage for Wegovy. Those numbers come from research put out by GoodRx, which pulled formulary data from a healthcare analytics firm called MIT, and that data covers more than 190 million people. NPR reported on the findings on April 22, 2026. The trend lines look the same for both drugs. The number of people with no commercial coverage for Wegovy went up 42% in a single year, ending up at more than 41 million. For Zepbound, the no-coverage number rose 12%, hitting more than 109 million. About 8.5% of people with commercial insurance, which works out to over 16 million Americans, now have no coverage for any GLP-1 prescribed for weight loss. And for the people who do still have coverage, 88% of them are dealing with restrictions. The most common ones are prior authorization requirements and body mass index thresholds. A lot of plans want a BMI of 40 before they'll approve the drug, and that's well above the BMI of 30 that actually defines obesity in clinical terms. A lot of this loss traces back to one decision. On May 1, 2025, CVS Health put out an announcement saying that as of July 1st, CVS Caremark would be pulling Zepbound off its three main commercial formularies: Standard Control, Advanced Control, and Value. The pharmacy benefit manager named Wegovy as its preferred weight loss drug after working out a new rebate deal with Novo Nordisk. CVS Caremark figured the change would save its clients somewhere between 10 and 15% year over year on anti-obesity medications. According to the company, more than 95% of weight loss utilization had moved to a preferred formulary product within 3 months. That number came from CVS Caremark itself and hasn't been independently audited. When asked about the change, CVS Caremark spokesman Philip Lando said the formulary strategy is about using competition to bring costs down, and that the high list prices set by drug manufacturers are the single biggest barrier to patient access. For the patients on the other end of all this, the experience was different. Coverage that had existed in June was gone in July. People on Zepbound got moved over to Wegovy. Then some employers, dealing with rising plan costs of their own, went and dropped Wegovy too. That's the road Lena ended up on. Zepbound, then Wegovy, then nothing. Losing coverage means paying out of pocket. Eli Lilly's cash price through LillyDirect for Lena's dose of Zepbound is $450 a month. The list price for Wegovy is somewhere around $1,350 a month before any discounts. Her doctor helped her switch over to a compounded version made by a specialized pharmacy, and now she pays about $300 a month. Compounded drugs aren't generics. They use the same active ingredient as the brand name versions, but they don't go through the FDA approval process. The financial pressure runs across a wide group. According to a KFF health tracking poll of 1,350 adults conducted in late 2025 and updated in March 2026, 56% of GLP-1 users, including 55% of the ones with insurance, say the drugs are hard to afford. 1 in 4 say they were very hard to afford. 14% of people who've ever taken a GLP-1 say they've stopped because of the cost. Doctors are describing a different kind of practice now. Dr. Catherine Varney, the obesity medicine director at UVA Health in Charlottesville, Virginia, has somewhere around 1,000 patients on obesity drugs. She told NPR that roughly 60% of them are now paying out of pocket. She said she feels more like a financial planner than a physician these days because of all the time she spends crunching numbers with patients trying to figure out whether it's cheaper to use insurance and hit the deductible or just skip insurance altogether. And the commercial market isn't the only place coverage is getting tighter. As of January 2026, only 13 state Medicaid programs are covering GLP-1s for the treatment of obesity. That's down from 16 back in October 2025. According to KFF, for states, California, New Hampshire, Pennsylvania, and South Carolina eliminated Medicaid coverage of these drugs for weight loss starting January 1, 2026. In California, all of the previously approved Medi-Cal prior authorizations for Wegovy, Zepbound, and Saxenda expired on December 31, 2025. The California Department of Finance projected the state's costs would have come close to $800 million a year within 4 years if coverage had stuck around. In Pennsylvania, state Medicaid spending on GLP-1 prescriptions had climbed from $223 million in 2022 to $650 million in 2024, according to the State Department of Human Services. Medicare's path has narrowed too. The BALANCE Model, a planned program that would have allowed Medicare Part D plans to cover GLP-1s for obesity starting in 2027, was canceled on April 21, 2026, after insurers fell short of the 80% participation threshold. The smaller Medicare GLP-1 Bridge program, which gives a $50 monthly copay to eligible beneficiaries, got extended through the end of 2027. It operates outside the standard Part D benefit and only applies to beneficiaries who meet specific clinical criteria. The same pattern shows up on employer balance sheets. Mercer projects that employer-sponsored health insurance costs will go up 6.7% in 2026, which is the biggest increase in 15 years, pushing the average cost per employee above $18,500. The Employee Benefit Research Institute estimates that covering GLP-1s could push employer premiums up anywhere from 5.3% to 13.8%, depending on adherence and eligibility. According to Aon, GLP-1s currently make up about 20% of total employer prescription drug costs, and total GLP-1 spending was up roughly 50% in 2025. Some employers have reacted by raising copays. Others have just removed weight loss coverage altogether. RWJ Barnabas Health, Ascension, and Hennepin Healthcare have all stopped covering GLP-1s for weight loss for their employees. Mass General Brigham Health Plan is no longer covering GLP-1s for small employers or individual commercial members in 2026. Kaiser Permanente cut base GLP-1 coverage for its California commercial and ACA members back in early 2025. In practice, the same person can lose coverage twice in the same year, from 2 different directions. The pharmacy benefits manager pulls a drug off the formulary. The employer drops the replacement. The state Medicaid program ends weight loss coverage. And the premium still goes up anyway, citing the cost of the drugs that aren't even covered anymore. For people who've been on a GLP-1 and then lose access, the medical pattern is documented. Studies of GLP-1 discontinuation show that patients regain the weight they lost, and improvements in cardiovascular risk factors slide back toward baseline. Diana Thiara, the medical director of the UCSF Weight Management Program, told KFF Health News that ending coverage will be quite negative for patients because the data shows people generally regain weight after stopping the drugs. New direct-to-consumer pricing has come into play alongside all these coverage losses. On April 1, 2026, the FDA approved Found-IO, an oral GLP-1 pill from Eli Lilly, available at $149 a month for self-pay patients. A few days before that, on March 31, Novo Nordisk launched a multi-month Wegovy subscription program with fixed monthly pricing through telehealth providers. These programs do bring the cash price down for some patients. What they don't do is restore the insurance coverage that got taken away. Lena's situation, as of the NPR report, is the situation a lot of patients are working through right now. She pays $300 a month out of pocket for a compounded medication. She's kept the weight off. She doesn't know whether the medication is going to stay available, whether the compounding rules are going to tighten up further, or whether her plan is going to change again next year. In her own words to NPR, there's so much uncertainty around these medications. The numbers behind her case aren't unusual. 12 million people lost coverage for one drug. 12 million lost coverage for another. 16 million have no commercial coverage for any weight loss GLP-1 at all. 3 states cut Medicaid coverage in a single month. The Medicare expansion didn't happen. And the premiums went up anyway. That's where things stand right now. If you'd like more reporting on how prescription costs, insurance decisions, and pharmacy policy are reshaping everyday life in America, consider subscribing to Dose and Demand. Comments help guide what we cover next, so we'd like to hear from you on this one. When a medication is working and the coverage gets taken away, where do you think the responsibility should sit? With the insurer, the manufacturer, the employer, or somewhere else entirely?